So let's review the clinical MCQ for nucleotide metabolism. Question 1 says, a 6-month-old baby becomes progressively lethargic and pale and shows delayed motor development. Laboratory evaluations reveals normal blood urea nitrogen, as a BUN, and there's low serum iron, and an hemoglobin is 4.6 grams per DL, and there's leukopenia. His bone marrow showed megaloblastosis, so note this megaloblastosis, which did not respond to treatment with iron or folic acid or vitamins or pyridoxine. So which means the megaloblastosis was as a result of the default in a pathway, which we'll look at soon. His urine developed abundant white precipitates identified as orotic acid. The underlying defect causing the megaloblastic anemia in the child is most likely due to which of the following pathway? The answer is actually pyrimidine synthesis. So the child had a deficiency of the enzyme, which might be the UMP synthase enzyme, and with the UMP synthase enzyme being deficient, we have the blockade in those pathways, which led to accumulation of orotic acid, and there was decreased synthesis of UDP. And without UDP being formed, we cannot form DUDP, which obviously gets to form DUMP, and DUMP cannot get to form DTMP. So this whole pathway is blocked up here. So all these ones cannot even happen. So this is why there's megaloblastic anemia. And don't forget, folic acid works here with the help of vitamin B12, so this tetrahydrofolate. And since the vitamins, even if you give them the supplementation of vitamins, folic acid, vitamin B12, or even iron or vitamin B6, it wouldn't work because there's accumulation of orotic acid at this point here due to enzyme deficiencies at below this level. So the enzymes is the UMP synthase. Now to question 2. Patients with Lesch-Nyhan syndrome have hyperuricemia, indicating an increased biosynthesis of purine nucleotides and markedly decreased levels of hypoxanthine phosphoribosyltransferase transferase. The hyperuricemia can be explained on the basis of a decrease in which regulator of purine biosynthesis. The answer is actually IMP. So that's the answer. So let's not forget, we said in the synthesis of purines, we have ribose 5-phosphate going to form phosphoribosyl pyrophosphate, which then goes to form 5-phosphoribosylamine. So this particular step, so this was step 1, this is step 2. Step 2 was synthesized by PRPP amidotransferase. So this was the step that was like the rate limiting step, and we said this enzyme is inhibited by IMP, inhibited by AMP, and also inhibited by GMP. So if we see any of this in the option, that would have been the answer. So what happens in Lesch-Nyhan syndrome is that we can't salvage our purines. So invariably there's low levels of IMP, and with low levels of IMP, there's nothing to inhibit the purine biosynthesis. So that's exactly why IMP is the answer. So let's look at for question 3 and 4 now. The anti-cancer drug 6-mercaptopurine is deactivated by the enzyme xanthine oxidase. A cancer patient being treated with 6-mercaptopurine develops hyperuricemia. So ideally, 6-mercaptopurine was meant to inhibit PRPP phosphoribosyl pyrophosphate amidotransferase. So the 6-mercaptopurine, I'll say 6MP, was to be converted to 6MP nucleotide form, which can inhibit this enzyme. And the enzyme that does this is hypoxanthine guanine phosphoribosyl transferase. So if the patient is given 6-mercaptopurine and this 6-mercaptopurine gets inactivated by xanthine oxidase, so we cannot have inhibition of PRPP amidotransferase. So this can lead to excessive production of UDP via the cancer cells, and once this UDP gets degraded, it will produce a lot of uric acid. So this is the reason why the patient could have hyperuricemia. Now, The physician now decided to give the patient allopurinol. So the question now says, what effect will allopurinol have on the activity of cis-mercaptopurine? It's very, very simple. Allopurinol will inhibit xanthine oxidase. So if allopurinol takes xanthine oxidase off the equation, cis-mercaptopurine is not inhibited any longer, or is not deactivated any longer. So what will happen is that there will be enhanced retention and potentiation of the activity of cis-mercaptopurine. So that will be the answer. Option C is the answer. Question 4 says, resistance of neoplastic cells to the chemotherapeutic effect of cis-mercaptopurine would most likely involve loss or inactivation of a gene encoding what? Now, if the cancer cells develop resistance, it means that there is no gene to encode hypoxanthine phosphoribosyltransferase transferase, which is the enzyme that actually relatively activates it to its nucleotide form. So if this enzyme, hypoxanthine phosphoribosyltransferase transferase, is mutated, so we cannot have its activation, and there can be no inhibition of step 2. So this step 2, as we said, is catalyzed by phosphoribosyl pyrophosphate amidinotransferase. For question 5 now, a 12-week-old infant with a history of persistent diarrhea and candidiasis is seen for a respiratory tract infection and pneumocystis jirovecii. A chest X-ray confirms pneumonia and reveals absence of a thymic mass. Trace IgG is present in his serum, which obviously came from the mother, but IgA and IgM are absent. His red blood cell completely lacks an enzyme in the purine degradation. The product normally formed by the enzyme is what? Now, what is now? This child has absence of a thymic shadow, so which means T cell is affected. So there's T cell absence. And this child also has just trace IgM present in serum, but IgA and IgM are absent. So there's also B cell absence. So the disease that affects both B cell and T cells is called SCID, severe combined immunodeficiency, which is as a result of a deficiency of an enzyme called adenosine deaminase. So adenosine deaminase is needed to deaminase adenosine into inosine. So the product normally formed by the activity of this deficient enzyme now would have been inosine. So that should be the answer. So the condition stated here is called SCID, severe combined immunodeficiency. For question 6 now, your 60-year-old female patient has psoriasis and has been treated with methotrexate for several years. And methotrexate functions by inhibiting dihydrofolate reductase. So we can't convert dihydrofolate to tetrahydrofolate. So this enzyme, dihydrofolate reductase, is affected by methotrexate. She has no other medical problem, and her preventive screening, including fecal occult blood test and colonoscopy, have all been normal. She had developed an anemia. Which of the following would you expect to find when working her up for anemia? So we'll expect to find a macrocytic anemia. There will be macrocytic anemia because she has folic acid deficiency or tetrahydrofolate deficiency. As a result of folate deficiency, we can't effectively convert DUMP to DTMP, and this reaction is affected, which can lead to megaloblastosis. So she has a macrocytic anemia. A patient has been recently diagnosed, question 7 now, with colorectal cancer. The physician treats the patient with a combination of chemotherapeutic drugs, one of which is 5-fluorouracil, 5-FU. 5-FU is effective as an anti-cancer drug because it inhibits which of the following enzyme? The enzyme that converts DUMP to DTMP is called thymidylate synthase. Antimidylate synthase is inhibited by 5-FU, 5-fluorouracil. So the answer to this is B, timidylate synthase. Question 8. A patient exhibits fasting hypoglycemia and lactic acidosis under fasting conditions. Hepatomegaly is also evident. A glucagon challenge only releases about 10% of the expected levels of glucose from the liver. The patient has also developed gout due to an increase in the levels of which of the following metabolite? Obviously, the patient has increased PRPP being formed. So the condition lacking here is actually, the enzyme lacking here is glucose 6-phosphatase, which is majorly in von Gierke's disease. Von Gierke's disease type 1A or type 1B, whichever one. You could go back to your lectures on glycogen storage diseases to find out the differences. So when glucose 6-phosphatase is deficient, glucose 6-phosphate cannot be converted to glucose. So glucose 6-phosphate accumulates within the cytoplasm. So it then shunts to the hexose monophosphate shunt and then goes to form ribose 5-phosphate. And ribose 5-phosphate eventually becomes PRPP. So this is why there will be increased ribose 5-phosphate and then there will be increased PRPP. So that's the answer here. And this is why there will be gout, because with increased PRPP, there will be a lot of IMP formed. And with IMP, you could have AMP being formed and GMP being formed. And when they are degraded, they will form a lot of uric acid. So this is why von Gierke's disease can also cause hyperuricemia. Question 9 now. A 6-month-old infant is seen by the pediatrician for developmental delay. Blood work shows megaloblastic anemia, although measuring of B12 and folate are in high normal range. Urinalysis demonstrates, upon standing, the formation of crystalline substance. Supplementation of the child's diet with uridine reversed virtually all the clinical problems. The crystalline substance was most likely composed of which of the following? This child had orotic aciduria. So the crystalline substance was more of orotate. The enzyme deficient in this child was also UMP synthase. So UMP synthase, two enzymes actually. Go back to your lectures to check the two enzymes that form UMP synthase. Considering the patients in the previous question, after uridine treatment, the crystals were no longer found in the urine. This is due to which of the following? Now, this is the trick questions. Uridine can function in two ways. It can enhance the production of UMP and also eventually UDP, which invariably, if these are made, we've bypassed the blockade up here. But if you say bypassing the mutated step of the pathway, that would have been wrong, because what the question said was, after uridine treatment, the crystals were no longer found in the urine. If the crystals were no longer found in the urine, then they now had another function. When UDP, UMP became formed, and to also add, we could have UTP here too. Now, don't forget, we said in the regulation of the pyrimidine synthesis, in eukaryotes, UDP, UTP, they all inhibit CSP2, which is carbamyl phosphate synthetase 2. So if they inhibit CSP2, which is higher up here, we cannot form even the orotic acid any longer. So it's by inhibition of CSP2 that the crystals became clear. So the right answer was actually E, not B, like many of you chose. Go. Question 11 says, an 18-month-old infant has had a history of recurrent bacterial and viral infections. The child has failure to thrive, developmental delays, and tremors. Physical exam shows a lack of peripheral lymphoid tissue. Blood workup shows lymphopenia. with normal levels of B cells. So take note, there's normal levels of B cells and circulating immunoglobulin. So B cells were not affected, B cells were spared. This child would most likely have a defect in which of the following enzymes: purine nucleoside pyrophosphorylase, that's the condition. Deficiency of this enzyme is the answer. Question 12. Individuals with gout are given allopurinol for long-term management of the disease. In such individuals, which of the following bases would accumulate in the urine? We have both hypoxanthine and xanthine will accumulate, because don't forget we said hypoxanthine is converted to xanthine by the enzyme xanthine oxidase. Xanthine is converted to uric acid by the same enzyme xanthine oxidase. So if we give, and don't forget we also said that guanine can also be converted to xanthine by the enzyme guanase. So if we give a drug that inhibits xanthine oxidase, we're going to have accumulation of hypoxanthine, which is coming from the breakdown of adenosine, and we'll have accumulation of xanthine also, which is coming from the breakdown of guanine. So that's exactly why hypoxanthine and xanthine is chosen. Question 12 now. A 1-year-old boy was brought to the pediatrician due to developmental delay, biting of his lips and fingers, and the presence of orange crystals in the diaper. So take note of this orange crystals in the diaper. Enzymatic analysis shows loss of 99% of an activity of a particular enzyme. The defective enzyme in this disorder would normally utilize which of the following substrate? The answer is guanine. It will utilize guanine. What this patient actually have is Lesch-Nyhan syndrome. So the patient has Lesch-Nyhan syndrome, and Lesch-Nyhan syndrome, the enzyme hypoxanthine guanine phosphoribosyl transferase utilizes both hypoxanthine and also utilizes guanine. So it doesn't utilize adenosine or guanosine or GMP, it's guanine. So it converts guanine. It's in this process PRPP gets added to the reaction and converts guanine to guanosine, and then converts hypoxanthine to guanosine monophosphate, I mean to say, and convert hypoxanthine to inosine monophosphate in the same reaction, PRPP being added to the structure. So considering the patient in the previous question, the orange sand in the diaper was composed of urate, sodium urate crystals. A 6-month-old boy was brought to the pediatrician due to frequent bacterial and viral infection. Blood workup shows a complete absence of B and T cells, so it has SCID. Radiographic analysis shows a greatly reduced thymic shadow. Treatment of the child will be stabilized proteins, reverses the deficiencies. The protein has which of the following activities? The protein can convert adenosine to inosine. So the protein is like, we are giving the deficient enzyme, which is called adenosine deaminase. So the protein is more or less like a supplementation of this enzyme that can convert adenosine to inosine, thereby treating this disorder called SCID. So this is the end of this lecture. See you guys in the next reviews.